is a middle-aged woman, and the indication for this pelvic MR was symptomatic fibroid. So, with the usual search pattern, I pulled up the sagittal T2-weighted sequence first, and I'm scrolling through it. So you can see the obvious lesion here. There is a T2 intermediate signal lesion in the region of the cervix, and there's just a small fibroid there. So at first I was thinking maybe this is, sorry, hold on. Is it too zoomed in still?
It's okay.
Here, yeah. Anyway, I was looking at this and I was reminded of a prior case where they had sent it for concern for cervical cancer, and there was a similar lesion in the region of the cervix. So I'm looking at this, and that turned out to be a prolapsing uterine fibroid. So at first I was thinking maybe this is a prolapsing uterine fibroid, and I'm trying to see where the, if it is a prolapsing fibroid, it's got to be a pedunculated one. So I was trying to look for the site of attachment to the uterus, and I'm going to show you other sequences. So then I pulled up the axial T2-weighted image, and I'm scrolling through it. Here is the endometrial cavity. Again, I see this T2 intermediate signal lesion. It's very well demarcated, cannot really see any site of attachment coming from above. And then this is what it looks like on T1 weighted, non-contrast. So it's very uniformly bright. So I know that there is some amount of hemorrhage or proteinaceous debris within it. And then again, I'm going to bring up the T2 weighted images. So what I see here is it's pushing the endocervical canal, compressing it. And then the margins, the epicenter of it looks like it's within the cervix itself. This is the cervical stroma, T2 dark rim of the cervical stroma. That's on one side. On the other side as well, perhaps there is a little bit of cervical stroma, and the T2 bright overlying cervical mucosa is right here. So then this is what it looks like on the post-contrast images, but because the pre-contrast is bright on T1, I'm going to show you the subtraction post-contrast images. It doesn't enhance. So basically what this is a nabothian cyst with hemorrhage within it based on its epicenter. Now, nabothian cysts typically are retention cysts, and we see them very commonly on imaging. And usually these are small T2 bright cystic structures. They are thought to be retention cysts from mucous cervical glands, endocervical glands. Sometimes they can be large, they can enlarge, and there is something called giant nabothian cyst. So anything more than 4 centimeters in size is said to be a giant nabothian cyst. So occasionally they can be symptomatic. And this is one of those examples where there is hemorrhage within this so-called giant nabothian cyst, and it's symptomatic. So I read this recently. I don't know from treatment perspective what they plan on doing, but this is an example of that. And then just to stir conversation, like I said previously, there was one case where there were multiple nabothian cysts, and we always struggle with differentiating deep nabothian cysts, so to speak. There's a terminology like that from adenoma malignum. And I don't know if others have any additional input, but this is the way I look at differentiating the two. Benign nabothian cysts from adenoma malignum is if there is enhancement, any soft tissue component, combined with, the most important thing is clinical symptoms of excessive watery secretions, vaginal discharge, then you tend to suspect that that might be adenoma malignum as opposed to just simple nabothian cysts. So that is my first case.
I knew this is a beautiful case because it really does look like a polyp or something on the.
Yeah. Right.
Yeah, that's gorgeous.
Either a polyp or a fibroid, prolapsing fibroid.
And then when it was T1 bright, I briefly was like, is this a huge like endometriosis deposit?
No, I'm not going to show you. That's a good thought as well. That's one of the differentials. You can have endometriosis within the cervix as well, deposit. That's a good thought. So
cool.
Yeah. Here is my companion case. And this is pretty straightforward and simple. This is a homogeneously T2 hypointense lesion. And you can see that there is, let me see if I can show you a better image. Yeah. This looks like a fibroid. It's pedunculated. You can see the site of attachment to the cervix. So this is a cervical fibroid prolapsing into the endocervical canal. And on the post-contrast images as well, it enhances like a fibroid. It looks very, it enhances, this is a pre-contrasty one. Sorry, let me show you. This is also a pre-contrast, never mind. But it enhanced very similar to the myometrium. So that was just a cervical fibroid prolapsing into the endocervical canal. And then this is my last case. So this is a question for everyone. This is an open forum case. The indication here was rule out urethral diverticulum. And I'm going to start by scrolling through the sagittal T2 weighted images here. This is an older postmenopausal lady. That's the clue. So if you look at the urethra, there's no urethral diverticulum in the expected location. There is nothing surrounding the urethra itself. But if you look at the inferior margin of the urethra, there is something here that is not normal. There is some T2 hyperintense crescentic structure, and I'm going to show you what it looks like on axial T2 weighted images. So scrolling from above below, starting from the proximal portion of the urethra, extending inferiorly, you have this circumferential T2 intermediate or hyperintense structure. It's not fluid bright. And then on the post-contrast images, that structure shows some heterogeneous enhancement. So here it is again, some heterogeneous enhancement. So this is soft tissue, not fluid containing, and it's at the tip of the urethra, right? It's not in relationship to the expected location of urethral diverticulum. What this is an entity called urethral caruncle, C-A-R-U-N-C-L-E, caruncle. And this is basically a soft tissue, well, you can't call it a mass, but it's a benign entity often seen in postmenopausal women. And it is said to occur because of lack of estrogen and friction in this region. And this is not a pre-malignant entity. It can cause itching or bleeding as well. So it's a nice textbook example of a urethral caruncle.
Beautiful. I had a case like this, and what I remember reading was that this really actually should not be an imaging diagnosis. Like you can see it on the skin.
So that's exactly right. You're absolutely right. The indication, when I read deeper into the history, was they said that on exam they could see this urethral caruncle, but they wanted to rule out a diverticulum because she had discharge and bleeding. And so I had never seen it on imaging. So I was excited to see this on MR, and I thought, let me share.
Yeah, and it's good to know about it. I remember like we kind of jumped, or I jumped like, okay, it must be a malignancy because I didn't know that these caruncles exist. But yeah, it's good to know.
Yeah, those are my three. So, all done.
Awesome. History of multiple myeloma.
This meeting is being recorded.
We saw like this is the prior MRI I'm showing, and we saw these multiple diffuse T2 hyperintense lesions scattered throughout the liver parenchyma, as we see here also on these axial images. And it is showing restricted diffusion, all these lesions. They are showing restricted diffusion and like homogeneous post-contrast enhancement. Accidentally, we saw venous varix of the left branch of portal vein. And this patient then underwent treatment, and after 3 months, we had repeat MRI, which is showing like complete resolution of these liver lesions. We don't see anything on the post-contrast images, as well as restricted diffusion images are not showing any lesions. So this is case just to show that extramedullary disease in the liver in patients with multiple myeloma. Then I have 2 more cases in patient with history of multiple myeloma. I will pull up the next case. Okay, so
this meeting is being recorded.
So this is like companion case to same the patient has history of multiple myeloma here, but when we scan the patient, we see these multiple lesions scattered throughout the liver parenchyma, kind of giving targeted appearance. This accidental noted liver cyst is there. And on the restricted diffusion images, they are showing like this diffusely scattered liver lesions. Also, this patient had small lesion in the pancreas, as you see here, in the pancreatic tail region. And on post-contrast images, it is showing like kind of targeted pattern of enhancement, like central filling in. This one. So this patient, then after this scan, like we gave the differentials, could be EMD or maybe metastasis from some other name, could be like pancreatic malignancy or something else. So on biopsy, this turned out to be pancreatic adenocarcinoma with liver mets, kind of giving appearance of like EMD, but the diagnosis was like adeno with liver mets in this patient. And then I have another case.
And what does EMD stand for?
Extramedullary disease in multiple myeloma patients.
Okay.
Like when
disease. Okay.
Other, like kidney or liver, like any other organ.
Got it.
At first, I thought these were colorectal mets. Have that targetoid pattern. Right?
Yeah, they definitely can look like this too.
This patient also has history of multiple.
This meeting is being recorded.
And again, we are seeing these multiple lesions scattered throughout the liver parenchyma. And we did not see any lesion in the pancreas this time, but these were like multiple lesions, again showing restricted diffusion and post-contrast enhancement. So here the enhancement pattern was like kind of showing some like washout on the delayed contrast phase images. And some lesions were showing like ring enhancement pattern. Yeah, here, like this lesion is showing ring enhancement pattern. So with history of multiple myeloma and these liver lesions, so again, they were not sure what's going on in this patient. So they underwent like a biopsy and it turned out to be neuroendocrine mets. So usually in the neuroendocrine mets, like if the mets are in the liver, we see like a fluid level, but in this case, we are not seeing any such like classic appearance to say neuroendocrine mets, but the biopsy showed neuroendocrine mets. So then where is the primary? We did not see anywhere the primary lesion. Only thing we saw is small lymph node. Let me see, it was here. Yeah, here we saw small lymph node, mesenteric lymph node. So then this patient underwent DOTA TET scan. And on DOTA, yeah, so like
This meeting is being recorded.
DOTA TET scan, that's what like we saw diffuse disease in the liver as well as this activity in the lymph node, which we saw on the MRI, and additional focus of activity in the distal ileum. So they are thinking that this is the primary lesion, neuroendocrine tumor, and the diffuse metastatic disease in this patient with history of multiple myeloma. So I just wanted to show different patterns of like, even though patient has multiple myeloma with lesions in the liver, it's not always EMD, like extramedullary disease. Like we saw these two cases with pancreatic adenocarcinoma with liver metastasis, and this is with neuroendocrine tumor and liver metastasis in patients with multiple myeloma.
Excellent. Isn't it amazing how small that primary is and how much disease is in the liver? One other point I was going to say is, yeah, whenever you see arterially enhancing mets and you think about neuroendocrine, I always then go like, make sure that you look in the mesentery right lower quadrant, for the primary. And then also always make sure you look at the pancreas because you can get neuroendocrine there too.
Yeah, that's what. These are the three cases I wanted to show.
Okay, so this was a patient, I'm going to withhold the history for a minute, and they were getting a CTA and this is what the aorta looks like. So their aorta looked fine up here. And then it looked like this. And I can show you the sagittal also. Any thoughts? Is the aorta thrombosed? So this is actually the arterial phase. And then this is a more delayed venous phase. So on both the arterial and the venous phase, the aorta is not seen distally.
Is it because of the ECMO cannula?
Yeah, good. Who's that?
That's Maria.
Oh, cool.
Yeah.
So do you know what kind of ECMO this is?
Not sure, but I've seen this before where it produces this artifact where the aorta and the IVC looks thrombosed because the blood is getting shunted into, or the contrast is getting shunted into the ECMO. And that's why they're not pacified.
Yes, exactly. So
Yeah.
this is a known artifact in VA-ECMO, which is venous arterio ECMO. So there's a great radiographics paper. I'm going to show you a couple of things from it, but there are a couple of known artifacts. One of them is when this aorta kind of disappears halfway through, and the other is when you get this this mixing or disappearance in the descending aorta. And I'm going to try to explain my artifact to you. So basically what's happening is in VA-ECMO, VA-ECMO is for patients who have low cardiac function or minimal cardiac function. And VV-ECMO is for patients who have poor pulmonary function. So in VV-ECMO, that's for patients, for example, like who have COVID, their heart is working fine. So you can pump the oxygenated blood back into the heart and the heart can still pump it out. Whereas in VA-ECMO, the heart's kind of taken out of the system. And so you have to pump it back into the artery. And in this particular case, the ECMO cannula is basically taking the deoxygenated blood out of the right atrium, and it puts it into an oxygenator, which is outside of the patient. And then it feeds it back in through this, the common femoral artery. And so the oxygenated blood is actually being pumped in a retrograde fashion. So this unopacified, common iliac arteries and distal aorta is all of the oxygenated blood that's getting pumped back in a retrograde fashion. And then it meets the contrast that's coming from your arm and basically going through your heart, because the heart is functioning a little bit. So the contrast is able to go a little ways down, and then it kind of meets the oxygenated blood that's coming up from the ECMO. Does that make sense?
Yes.
So yeah, so just know that this is an artifact. Apparently there are things they can do. They can change some of the ECMO settings temporarily so that you have less of the retrograde flow. So you can basically kind of turn off the pump for a little bit if you really, really need to do a CTA, because these patients are actually prone towards thrombosis. And if you're doing a CTA in order to find out if they're having a clot in their heart or in the IVC or anything, and you really want to pacify everything, it's not going to be successful if you have all these artifacts. So sometimes they can temporarily just briefly turn off the ECMO or turn down the setting to prevent this artifact. So I just thought it was really interesting, something for us to know. Don't call this a aortic thrombosis. This is just a known ECMO, VA-ECMO artifact. Okay, I'm going to pause. Sorry, repeat that.
I was saying, what if there is, having a true thrombus in this region must be uncommon because there is high pressure flow into the aorta, correct?
Yeah, but I think it's a little tricky. I guess I don't know exactly why they're prone towards thrombi. Part of it is probably because they have this huge catheter here. I guess they're prone towards both thrombi as well as bleeding. I've actually seen some big bleeds from when they remove this catheter. And I think they actually, I think they have to anticoagulate them in order to have this catheter in.
Oh, yeah.
So they're prone towards both bleeding as well as, I think, thrombi. You're right. It's not like that common to have your aorta thrombose, but I think also there's all this like mixing of blood, right? It's because like it's like pushing in the retrograde direction. Your heart is also pushing in the opposite direction. So there's like mixing of blood. So the hemodynamics, I think, are very complex.
Right.
But apparently these patients are prone towards both of those. So you might be commonly doing a CTA, and then you might, see these artifacts. We actually had 3 patients in a row with the same artifact. And then we're like, okay, what's going on? We have to understand this. So, and yeah, I would recommend checking out this, this radiographics paper. It's called CT angiography of VA-ECMO, and it's from last year. Okay. Okay, so this is my next patient who has this large liver mass. You can see it's kind of T2 intermediate and heterogeneous. Oh, I should do that. There wasn't any fat in the mass. And pre-contrast, there's no real hemorrhage. This is the 30-second, so like the arterial phase. It's not really hypervascular or hyper-enhancing. And then this is the more delayed phase, so we have some progressive enhancement. So what would you think about this mass?
The tissue looks like fibrous tissue, perhaps delayed enhancement, T2 hypointense.
Exactly. So yeah, that's like we're in the fibrous kind of differential. So we're not really thinking like an HCC with arterial enhancement washout. We're thinking more like, could this be a cholangio? Could this be a metastasis? Occasionally solitary fibrous tumors are in the liver and they can have progressive enhancement. Those are the main things I thought about, or we would think about. But this patient, interestingly, had a meningioma resected from their brain. And this was biopsied and was identical to the brain meningioma. So this is a meningioma metastasis to the liver. Not something we would ever bring up, just except if you get that history, you know that they have a meningioma. It's apparently extremely rare to metastasize to the liver. About 80% of meningiomas are grade 1, are considered benign. Another 15% are grade 2, which is atypical. And that's what this patient's meningioma in her brain was, an atypical meningioma. And then 5% are malignant meningiomas that are known, they're more aggressive, they're invading other parts of the brain, and they're known to metastasize. So even though she had a grade 2 meningioma, she ended up with this large liver metastasis. Looking in the literature, it's very, very rare. When meningiomas do metastasize, they usually go to the longer bones. Liver mets are very, very rare. In one case report I read, they said that sometimes they present with hypoglycemia. And their proposed theory, it's sort of like the solitary fibrous tumor. They create insulin-like hormone and they make, which can lead to hypoglycemia. Meningiomas, I don't think they make that hormone, but they said one of the theories of why you get hypoglycemia is because it's occupying a large part of the liver, so that it's like taking up glycogen stores, as well as the fact that meningiomas like eating glucose. So I don't know if that's really, I mean, it's so rare that I don't know if this is like just a real theory or fact, but anyway, this, just so you know it exists, this is a meningioma met. Okay, this is my next case. This one was like, we kind of debated about this case in our local interesting case conference. And I'm curious to know what you guys would have called this. Appearance of the endometrium. Some of it is kind of going into the myometrium.
So just based on this one T2 sequence, they don't look like your typical cysts, subendometrial cysts, right? But yeah, someone says hyperplasia.
Good thought. Hyperplasia. You're saying subendometrial cysts, like just regular cysts, or even we also considered adenomyosis.
Adenomyosis, yeah, exactly.
Yeah, and you can see that like it's it's kind of enhancing like these things here. I'll show you a couple of other. This is the space image. It's kind of impressive.
It kind of looks too T2 hyper intense, almost like a hemangioma.
Oh, that's a great thought.
Yeah.
I like it, but it wasn't a hemangioma.
They look like some sort of tubular glands that are dilated.
Yeah, and actually that's basically what this is. This is glandular proliferation, but anyway, they did multiple biopsies of this, and it basically came back as proliferative endometrium and polyps. So if they and the OBGYN said like when they looked at it, it looked like carpeting polyps. I've never seen polyps, like extensive polyposis look like this, but that's what this is. And I guess like it even kind of like it's invaginating and growing into here. We were like, oh, this is like invading the myometrium. This is adenomyosis, or maybe a combination, but they did not get any adenomyosis in their biopsies. Kind of cool. Okay.
This, I'm going to step back. This was the prior case that was presented recently. Aarti reminded me. So anyways, at that time, I thought it was like a kind of redundant sigmoid that prolapsed, and patient couldn't evacuate at all because we don't see any contrast in the anal canal. And this was causing obstruction. And so I recommended a defecogram. So patient got an MR defecogram, and unfortunately, when she evacuates, we don't see as dramatic of findings that we saw on fluoro. What we do see is like, I think this is her cul-de-sac here. So here is her middle compartment, and this is the cul-de-sac, and that herniates as well. And the reason now why I think it's an enterocele is because here on the defecogram, there's lots of small bowel here, but as the exam progresses, it all kind of herniates posteriorly into the posterior compartment right there. And I think that's coming from that, peritoneal seal, or, the cul-de-sac that's herniating down. But at that time, I think the small bowel also herniated down. But
amazing how much more you see on the fluoro study.
Yes. So the question is there also a component of a sigmoid in here? And I can't tell on the fluoro or on the MR. So what I was thinking, I was talking to my colleagues, Cameron, and then Tony, our fellow. And so I think what I'm going to do now is have her come back and do the defecogram just with rectal contrast and not give her the oral, and see what her rectum looks like. Because I think there is a small bowel enterocele. And then if that doesn't help me answer the question about the sigmoid, then give her oral and then hang out and then, do it again.
Nelly, I have a question here. Where is the rectal contrast here?
So we administer that's why I don't think this is a rectocele, because we administered it, and presumably it's here, somewhere here, right?
Okay.
But that doesn't come down. It's the other things that come down.
Got it.
If it does come down, it's like up high, maybe in the sigmoid right there, and that prolapses down instead of it coming down the normal pathway.
Got it. I agree. It does suggest small bowel there. And actually, like, you look at the top of that column. Doesn't that look like small bowel?
Top of what column?
Top of the column, up higher.
Oh,
yeah, there. Like the top of this loop that's coming down right in front of like S2, to me looks kind of like small bowel. Yeah, that thing.
Yeah, and it's all, yeah. Okay.
Nelly, question. Do you guys do your MR defecographies supine, lying down?
No, it's lateral decubitus.
I see. And this is sitting down.
So recumbent
position,
yeah.
Right?
Yeah. Defecogram is, yep, exactly. She's on the commode here.
Yeah. I've seen sometimes that, gravity versus no gravity can make a
Yeah.
big difference. Too.
Yeah, and actually she told me that too, because when I tried it, I just do a quick physical exam when they're, before we administer the rectal contrast.
Mhm.
And she said, I'm not going to see what she has if I just examine her in the like recumbent position.
Mhm.
And so she told me she has to be upright. And so that she got into an upright position and then induced the the rectal prolapse.
Mhm.
So I think, yeah, I agree with you. I think the gravity component is, so I'm going to bring her back and I'll have a follow-up.
You could even have the surgeon there so that like you guys could do a clinical exam while the bowel is out,
The clinical exam to look for, you could see, like, what do you mean? I mean,
Like to like when can you see this bowel outside of her? Like, couldn't you tell if it's small bowel or rectum or sigmoid?
it's rectum. I mean, before we do the procedure, it was rectum, like rectum.
No. I mean, after she like.
Oh,
example,
after she
yeah.
evacuates. That's a good point. I didn't look at her after. Yeah. Like maybe she goes and then like stands up and then we look at it.
Yeah. I know it's complicating everything, but
yeah.
Because there'll be a peritoneal lining for the small bowel, whereas if it's just sigmoid or rectum, it's like the rectum is extraperitoneal. I don't know how.
Nelly, actually, now I see some haustra on the very bottom. Yeah, like over there. I feel like it might be both. Like on that last still image. Keep going. Right there. I feel like I see haustra too. I don't know.
All right.
Anyway, you'll have to give us the follow-up.
All right, so I've got a CT and an MR here to show you all. I'll start with the CT axial images, and there are going to be several observations. Just let me know sort of what you're seeing as I'm scrolling, and if you'd like me to show anything else. I'll try to scroll slowly.
You can see that markedly dilated stomach pulled
There's
towards,
like a mass or something in the retroperitoneum causing like malignant obstruction.
Yes,
And
good. So there's
bacteria.
this, yes, exactly. So there's this irregular soft tissue in the retroperitoneum. There's, marked dilation of the stomach and proximal duodenum that sort of extends up to this irregular soft tissue. There's hydronephrosis, like you mentioned, with a delayed nephrogram. And then all of this irregular soft tissue continues extending inferior within the retroperitoneum.
Does the patient have history of breast cancer? If it's a woman.
No history of breast cancer or other malignancy.
It's a new.
I'm thinking urothelial.
Oh, that's a good
All
one.
right. Yes, so let me show you the MRI just for comparison. The MRI was actually performed because they were worried about biliary obstruction. There wasn't any bilbil on the CT. There was distension of the gallbladder, and I think if you look carefully, there's potentially a little bit of soft tissue that extends up toward the neck of the gallbladder. So potential gallbladder involvement and a cause for that distension.
I would add
the MRI isn't. Yes.
Nelly, what'd you say? You would add what?
I would also add pancreatic cancer in there in addition to urothelial.
Cool.
That tissue is
that's
very
a good
dark
thought.
on T2. Mm-hmm.
Yeah, so this is when I became involved in the case, and that's a really good observation. I knew that the tissue is pretty hypointense. So we mentioned breast metastases, urothelial, pancreatic. Any other thoughts?
I mean, I think you have to put. I mean, can we? Retroperitoneal fibrosis. Can I have this appearance? I mean, they're usually bilateral. I mean, yeah, for sure, we have to rule out like malignancy.
Yeah, so RP fibrosis is a good thought. That was discussed in the initial reports. I believe usually it's more centered around the aorta, a little bit lower down, maybe like L4, L5 level. I've seen, classically described. I've seen other metastases do this. I've seen prostate do this. I think I've seen lung do this.
Also gastric signet ring cell can do this, but
yes,
it looks
exactly.
like the stomach
so this is
really distended and I don't see a gastric mass.
Yeah, that's a really good thought. So it's near the stomach and proximal duodenum, and there's obstruction. So that would be another really good possibility. When I was looking at this, my friend had called me about the MRI and was wondering what I thought. And I saw the hypointense, almost sheets
Skeletal
of
muscle,
abnormal
yeah.
soft tissue, which to me sort of reminded me of cases I've seen of urothelial carcinoma in the bladder, specifically plasmacytoid urothelial carcinoma, which more commonly occurs in the urinary bladder and is sort of known to have irregular sort of infiltrative T2 hypointense sheets of soft tissue extending along fascial planes. I have not seen in the radiology literature cases of plasmacytoid urothelial carcinoma, but it is mentioned in other sort of subspecialty literature like pathology. And so I thought it would be an interesting case of plasmacytoid urothelial carcinoma and suggested that to him. When I look more carefully at this, maybe there's a little bit of a more focal hyperattenuating or enhancing mass along the ureter here. And sure enough, it was biopsied via endoscopy and it came back plasmacytoid urothelial carcinoma.
Wow, what does it do on other sequences on MR? It enhances brightly or hypo-enhances?
I believe it sort of hypo-enhances. Let me double check real quick. Yeah, so this
There's a
infiltrative
lung
soft
mat
tissue is
too.
sort of hypo-enhancing. Yeah. And then let me pull the diffusion down. And I need to, oh, I can do this. Nope, it's not going to let me split it. Let me get to the high p-value just for illustration. So not that impressive on the diffusion.
Right.
So yeah, again, in the radiology literature, I could only find descriptions of plasmacytoid urothelial carcinoma described in the urinary bladder, and just sort of classically presents as hypointense sheets of malignant tissue extending along fascial planes.
Wow.
Great
very
job.
impressive.
I just Googled it and I'm reading plasmacytoid urothelial carcinoma is a unique variant of invasive urothelial that has a striking resemblance to plasma cells and is known for its aggressive behavior. The 2016 WHO classification now recognizes signet ring cell and diffuse urothelial carcinoma as similar to plasmacytoid. So anyway, it's interesting because the several cases I've had where like there's weird infiltrating tumor in the retroperitoneum, I have thought about signet ring or have been signet ring cell. So it's interesting that this is similar to it. But yeah, it sounds really aggressive. And like you said, it can spread along fascial planes. Cool, great case.
Yeah, very cool.
Thank you.
Okay, Nelly, you want to go?
Flank pain. Flank pain, and there's our culprit stone causing hydro. So the patient underwent a stent placement, and this is what it looks like. And the urology they were getting like kind of serial stent. Serial radiograph, and then this is what it looked like on this follow-up. Just making sure, following up on this patient's, and then this is what it looked like later. What do you guys think?
They
Hello?
eventually removed the
okay.
stent.
Yeah, they removed it, but they like left the upper pigtail there.
Yeah.
Like it
so that's what
fractured.
like fragments, right? Or so we thought. So we found out that actually this is a dissolvable ureteral stent.
What?
No
Yeah.
way.
Yeah.
Gosh.
Wait, what does that even mean?
And
Yeah.
well, so now they're using these the resolvable stents, like dissolvable stents, sorry. Like polyurethane stents or something like that, and it dissolves. And over time, because otherwise the patients have to come back to have the stent removed once the stone passes. With these dissolvable stents, they don't have to come back.
That
What is the time frame, Nelly? What is the time frame when they
The
dissolve?
time frame, so initial presentation until that last image, it was almost 2 months.
That is so cool. I do have a question. Like, so part of it hasn't like the rest of it hasn't completely dissolved yet. But it's interesting that the part that hasn't dissolved is like in the kidney. So I wonder if like there's something about the concentration of the urine that's different in the kidney versus like the rest of the ureter and bladder. I don't know. Just
That's a good point. I don't know.
but super cool. Okay, I have one.
While you pull up yours, I think drug delivery via.
Sorry, Anu, go ahead.
Yeah. No. While you pull up your case, I just wanted to share what I looked up. Drug delivery via biodegradable urethral stent for treatment of upper tract urothelial carcinoma. So biodegradable stents for that.
Super cool. Okay, this one is I have on PowerPoint, so I'm just going to show you guys a PowerPoint. It's a follow-up to a case that I showed probably like a year and a half ago. And somebody was watching our recording and asked me to send them some images from it because they wanted to use it for a presentation. So I went to go get the images, and then I saw that there was like now a year and a half of follow-up. So I thought I would give you guys the follow-up. So this was a renal mass that was enhancing. And so it came to IR for ablation, and they were going to do a cryoablation. So the interventionalist biopsied the mass. It came back RCC with clear cell features. And then they put 3 probes in and they did a cryoablation. 3 months after the cryoablation, it looks like a pretty typical cavity. We did not see any enhancement to suggest residual lesion. And then 4 months after the ablation, it started looking like this, where there was more kind of thick, soft tissue along the edge of the ablation cavity. And then 6 months after the ablation, they came back and we have an even thicker rind of enhancing soft tissue that's now kind of invading the musculature back here. Big kind of cavity, but lots of thick rind of enhancement. 8 months post-ablation, they come back and there's now like a big soft tissue mass. So we biopsied it again and it came back all blood and neutrophils. They did multiple core biopsies. There was no malignancy in this soft tissue mass. We basically diagnosed this as a pseudomass post-ablation, and they came back 13 months post-ablation and it had turned into this. So basically the pseudomass is now liquefied and it's actually like extending up onto the spleen now. So then we stuck a drain in this. Oh, and it's actually going all the way down here into the psoas. So we stuck a drain in it and it was infected with E. coli, but we drained it and now the patient's doing well and the pseudomass is basically drained and gone. So at the time that I presented this to you guys, we'd already thought it was a pseudomass, and I showed you guys this paper, but I just want to show you this paper again. It's from the Brigham, Dr. Silverman's group, and they do a lot of renal mass biopsies and ablations. And so they noticed, and they noticed that on several of their cases, they would get the pseudomass. And they ended up biopsying most of their pseudomasses because they wanted to see, like, is this tumor, tumor seed tracking. And what they found in this paper, to show you this is the title of the paper in case anyone wants to read it. I'm having trouble with my share screen, but anyway, what they found is out of the 310 ablations, I think, they had 6 cases of a pseudomass. They biopsied 4 of them, and 1 of them I think was surgically resected, and all of them came back pseudotumors. And one of their, it was a little bit more common with cryoablation than RF ablation. And one of their theories on why this happens is that at the tip of the probe, the cryoablation probe, it's minus 135 degrees, but along the course of the probe, it is also like minus 30 degrees or something. So their theory was that, it's 130 at the tip, but then minus 35 along the way. And so their theory is that they're damaging some tissue, like they're actually kind of like, you're kind of like cryoablating the fat and the skin at like that, just by the probe being there. And that was what induced these pseudotumors. In all of their cases, they actually involuted over time. In our case, we have this unusual case where it got infected and had to be drained. So just kind of, if you see an enlarging mass after an ablation and it has this kind of appearance, I mean, you're probably still going to need to biopsy it, especially when it turns into something like this, but there is something called like a post-ablation pseudotumor. And the chat, oh, KJ, oh, Maria and KJ say, cool case.